name's Heather, practitioner that works for the Suspected Child Abuse and Neglect program at Sick Kids Hospital. I'm presenting today with two of my colleagues, so I'll let them introduce themselves.
My name is Karla Wentzel. I'm a nurse practitioner with the Suspected Child Abuse and Neglect program at Sick Kids Hospital as well.
And I'm Dr. Jasmine Eliav. I'm a child clinical psychologist with SANE.
So I have a few just housekeeping points that I need to get through before we can start the presentation. So first of all, for participants that are listening in French, click on floor at the bottom left of the screen and select French. To see and follow along with the PowerPoint presentation in English, click presentation on the top left of the screen. To follow along with the presentation in French, download the French version of the presentation by clicking on Documents on the right. Feel free to download the presentation in both English and French by clicking on Documents on the right. We will have about 5 to 10 minutes at the end of the webinar for questions. If you want to submit a question, you go to the toolbar on the right, click on Messaging and then Participants, type in your question, and you can submit your questions at any time. And if you are watching the webinar in a group, please enter the number of participants in the group by clicking on Messaging and then Participants. I think that is it for housekeeping. So we're here today to talk to you about the medical and psychological aspects of supporting victims of human trafficking. So I will be talking first a little bit about a case study, and then we'll go through some of the things to consider from a medical perspective as well as a mental health perspective when working with this population. So this is a case study of a real patient of ours that we were involved with. So I will just briefly go through the case study. So she's a 15-year-old female. I actually saw her, I believe it was onto the emergency department at Sick Kids for abdominal pain and nausea that had been there for about a month. The emergency department staff did do a HEADS assessment, so a typical adolescent sort of screening assessment, and they did get a little bit of information about her social situation. So she was not in school, she was a smoker, sexually active with men and women, she'd had recent STI and HIV testing and it had been negative. In terms of the assault history, she said she was assaulted by an unknown male on the morning about 3 days ago at about 7 o'clock in the morning. After that, she was seen at another community hospital, but declined having assessment from a sexual assault perspective. She actually, in the emergency department, only mentioned the abdominal pain because she was wondering whether it was related to the sexual assault. She came into the emergency department with her friend. Because of her history, scan was called, and I went into the hospital to see her. So when I saw her, I got a bit of a medical history. She had a history of depression and anxiety. She'd had multiple pregnancies that had resulted in miscarriages, and she was not on any birth control at that current time. She'd had multiple sexual partners, both men and women, and she had been exchanging sex for money and drugs. Really survival sex, just trying to stay alive with whatever she needed. And from the pain perspective, she was having some lower crampy abdominal pain with nausea and vomiting for a few weeks and an intermittent fever. On social history, she was a Crown ward. She'd lived in group homes and youth treatment centers, and had multiple admissions to the hospital for suicidal ideation. She did have an extensive drug use history, mostly alcohol, marijuana, and Xanax is what she told me on that day, although really she did say that she would pretty much do any substance that she had access to. And she was really not, I think she was registered for school, but she was not attending school and certainly not passing. So my plan on that day was to do some medical care in the emergency department. So I did a physical and genital exam, did some STI testing, gave her a hepatitis B vaccine, did a suicide screen to make sure that she wasn't suicidal, and I made a referral to our psychologist for her to see. She did end up being admitted to the hospital. She had pelvic inflammatory disease and spreads. So she was admitted to the hospital for about 4 days.
So it's Dr. Jasmine Eliav speaking now. When she was admitted into the hospital, I was asked to, she was referred to me. So I went into the room on the ward to visit with her. I saw her, she presented in a hospital gown. She looked very vulnerable and quite young. In our program, we have teddy bears to hand out to the kids that we see. She requested a teddy bear. She acted in a bit of a regressed manner. She was in there with a female friend and was resistant to allowing the friend to leave the room. She deferred to this friend, who could have been her age or a bit older, to provide her medical history, her social history. So her friend began to describe a family history of alcoholism and drug use, using heroin, cocaine, meth since the age of 7. In between her friend's account, our patient would add in specific details, but seemed to reference her friend as she did so. So there was a good sense that she didn't have the autonomy to speak freely. She talked about having a history of blacking out, so she really couldn't clearly say how many sexual assaults she had experienced because she felt that many had happened without her knowledge. She described being currently homeless and kind of coming in and out of homeless experiences. And she looked out the room quite often, describing that she had a male friend downstairs who was waiting for her. They had offered for him to come up, and I had sort of said, oh, I'd be open to that. But she said no. She was very vague about the relationship, charge of the nature of information being provided. She said that her friend downstairs she met at a truck stop in the middle of the night. She described it as being full of trucks with men, and they all hang out together, where girls get drunk together or do drugs with men and kind of get passed around. She met her boyfriend there. She is trying to understand his motivation. So why is he interested in her? She says she's been used in the past, but was beginning to enter into a grooming phase with him. I could feel the struggle in her around the grooming aspect of this, or trying to understand if he was being kind to her. She described him as being different. She said that he offered her safety and drives and offered to help her. She wasn't sure whether that would continue over time. Gave her keys to his apartment so she was no longer homeless. And she noted she'd been trafficked in the past, but that it had felt very different than this. So she wondered if this was trafficking or whether she was really engaging in a relationship with him over time. In our second therapy meeting, she came in by herself for at least a portion of it. She described a history of sexual abuse. She became very tearful during this and really talked about having unsupportive, disbelieving caregivers at the time. And she had presented to our program at SCAN and remembered being there. She was placed in care at age 13, talked about being in and out of locked facilities, group homes, foster homes, ran away, lived on the streets for a while, and there was a bit of a sense of fear that her boyfriend would kick her out of the apartment if she was unwell. So wanting to keep them, ran away, lived on the streets for a while, and there was a bit of a sense of fear that her boyfriend would kick her out of the apartment if she was unwell. So wanting to keep the medical information that was happening in our clinic really contained and away from him. And she talked a lot about wanting to get pregnant and the fantasy of sort of having her own family. And I thought that directly tied into her caregivers being disbelieving and unsupportive. Just imagining herself meeting the needs of her baby, being able to start this life with a boy or a man who seemed to care for her and want to take care of her and meet her basic needs. So really just starting to set up the scene for a fantasy-based approach to her next phase.
We're going to take a break from the case there and talk a little bit about human trafficking and what it is. I've listened to a presentation by Julie Moore prior to this where she talked about human trafficking. So I'm not going to go too much into the dynamics and the definition. We'll talk really more about the medical care and psychosocial care, but just briefly, the definition of human trafficking is it involves the recruitment, transportation, harboring, and or exercising control, direction, or influence over the movements of a person in order to exploit that person, typically through sexual exploitation or forced labor. It is often described as a modern form of slavery. So human trafficking can be for multiple purposes. For the purposes of this presentation, we're just talking about sexual exploitation, but you can also be trafficked for organs and for labor as well. So in order for to meet the definition for human trafficking, there has to be three things. To meet the definition for human trafficking, there has to be three things. So first, there has to be the act. So whether that's recruiting or transporting or harboring or holding people against their will, there has to be a means. So it could be threats or use of force. More often in the adolescent population, we see manipulation and coercion and deception and abuse of power as a means, and there has to be a purpose. So that has to be exploitation of some kind. As I said in this presentation, we're talking only about sexual exploitation, but it could be for other reasons as well. When we're talking about commercial sexual exploitation, there are a couple of phases that you will most often see victims or survivors go through. We actually had a really good video that we were hoping to show today, and if anyone's interested, you could email us. I'll send you the link because it's a survivor that's talking about her trafficking experience and talking about going through these various stages. I believe it's actually called stages. But essentially what we do see is there's a luring stage. And so that's often when the traffickers will find people that they think are at risk or people that they think will be easy targets in order to lure them into trafficking. Oftentimes we do actually hear that some traffickers will hang out outside of group homes, for instance, or hang out outside of places where a lot of youth will, at-risk youth will hang out or get together. And they're really looking for those easy targets that they can manipulate and then exploit. So there's then a grooming and gaming phase. So this is the honeymoon stage that Jasmine was sort of talking about in the case study. New relationship and feeling like, this guy is amazing. He calls me his queen. It's almost too good to be true. So this is where some of the the manipulation starts to come into play, and there's adolescents will think this person's going to save me. I'm going to have a new life with this person. It's almost like, a Disney fairy tale, for instance, that this is the answer to all of my problems. So in this phase, a trafficker will buy things, take them out for dinner, take them to get their nails done, things like that, to make them feel really special. And then at some point that you enter into the coercion and manipulation stage. So that's often when mixed messages will start to be sent. So, one day everything is great and everything's perfect and you're going to have the life that you envisioned. And the next day, maybe the trafficker is a little bit perfect and you're going to have the life that you envisioned. And the next day, maybe the trafficker is a little bit colder. Maybe there starts to be a little bit of pushback, a little bit of violence even, and that individual is left feeling like, I will literally do anything to get back into this person's good graces. I just want that life that I was promised or that I want. This person's going to save me and I'll do anything.
That also feeds into the history of trauma that a lot of these young women come into this with, or young adolescents, when they have complex trauma histories where they had sort of insecure or disorganized attachments with their own caregivers in their relational style. And so this also pulls on that previous history that they've had, some of them from birth.
And then you enter the exploitation phase where the trafficking begins. And this can be threat or force is used. More often we see that individuals will actually still consider this person, their trafficker, to be their boyfriend, and that this is sort of part of the relationship that they have that's going to get them to that better life that they've sort of been promised. That's what we tend to see more often, but there can be a variety of ways that people are exploited.
Believing in that relationship and believing that that relationship is what you want it to be is protective in a lot of ways, because if they understand the reality of it, that can cause a lot more distress and suicidality and the understanding of exploitation. That might be too much for them to understand in that point in time.
So trafficking is a pretty big business, and traffickers are often very organized and very methodical about going through each of these stages. You can actually, it was shocking to me when I found these stages. It was shocking to me when I found this out, but you can actually buy books on Amazon that talk about how to become a pimp. And this is on the screen is an excerpt from one of those books called The Pimp's Mindset. So I'll just read it. It's fairly disturbing, but this is the mentality, I think, of a lot of pimps, and it's also something that's passed down from generation to generation or through gangs. So you'll start to dress her, think for her, and own her. If you and your victim are sexually active, slow it down. After sex, take her shopping for one item. Hair and or nails is fine. She'll develop a feeling of accomplishment. The shopping after a month will be replaced by cash. The lovemaking turns into raw sex. She'll start to crave the intimacy and be willing to get back into your good graces. After you have broken her spirit, she has no sense of self-value. Now, pimp, put a price tag on the item you have manufactured. So you can really into exploitation is all sort of illustrated there. When we're thinking about how to help victims of human trafficking and what we can do, I think there's a tendency often to think about, this individual needs trauma assessment and treatment. They need, lots of therapy. They need, let's do all these amazing things for them. But really, this Maslow's hierarchy of needs, though it's, quite old, is really nice at illustrating, that really we need to start at the bottom, and we need to be thinking about the basic needs of some of these individuals. So starting with physiological needs like food and shelter and a place to rest and clean clothing is really the place that we need to start oftentimes, and then moving up from there. But if you see, for instance, an individual, starting with physiological needs like food and shelter and a place to rest and clean clothing is really the place that we need to start oftentimes, and then moving up from there. But if you see, for instance, an individual like we were talking about in our case study, she's not ready to really enter into any type of trauma assessment and treatment or anything like that. She's homeless, she's just not there. So we need to start thinking about basic needs first.
And for most of the kids with complex trauma histories, their basic needs have not been met for long periods of time as well. So although we might want to start higher off, they've maybe never had the opportunity to get there before, and they may be used to not having their basic needs met.
In terms of stats and how common human trafficking is, I think these stats, although they're quite old, are really only actually just the tip of the iceberg. I think that there's a lot of trafficking that goes on that is never identified, even though probably in our work, we are seeing victims or survivors and we're not identifying them. They're out there. There has been an increase in occurrences between 2013 and 2014. There's a huge increase, as you can see. I think that part of that has to do with trafficking being more common, but also I think that we're just getting better at naming it. So I do think that these are patients that we would typically have seen at our program, and we would have called it something different, or we would not have identified sort of the dynamics of trafficking that were happening. That being said, the numbers are, there's 16,000 Canadians are being trafficked in Canada. Most of those cases, so this isn't like whatever that movie is, Taken, where, it's a foreign girl being taken to another country and trafficked. A lot of these individuals might be trafficked in the city in which they live or a city next to the city in which they live. Some of them live at home even. 90% of them are female, and 63% are between 15 and 24. I think the statistic is that the average age an individual is trafficked is 13 to 14. It was when they first start being trafficked.
And that's just interesting from a developmental standpoint, because we're looking at the development of romantic relationships on a normative trajectory. So you can see why that would be an excellent time for grooming and or the fantasy of having somebody take care of you at that developmental stage.
The risk factors for trafficking are pretty much what we would probably expect. For trafficking are pretty much what we would probably expect. So Jasmine already talked a little bit about the developmental implications, but really anything that places an individual at risk or makes them more vulnerable is going to be a risk factor. So poverty or homeless youth, history of physical and sexual abuse we see very often, or family dysfunction. Transgender and LGBTQ individuals are more at risk as well. Substance use, behavioral challenges, mental health issues, gang involvement, pretty much all of those risk factors, it's probably what you would expect to see. Anything that a trafficker can see and then exploit is going to put somebody at risk.
So years ago, when we looked at internet sexual exploitation, we used to tell kids that the risk was in providing information about your name or where you lived. But really what we came to learn over time was that it was around your vulnerability. Online and your social emotional vulnerability. And that holds true here. The people that are looking to groom these young adolescents are really looking at the risks within their and the vulnerabilities within their social, emotional, and cognitive development.
And so as I sort of said a little bit earlier, we do, I think, see victims or survivors of trafficking sort of every day, and we're getting better at identifying them, but oftentimes we don't. Again, I think the statistic is that about 90% of individuals who have been trafficked have tried to access some sort of help, whether that's medical care or psychosocial care, and oftentimes they're just not identified, or the individual who has been trafficked is not forthcoming. And sometimes our system is not necessarily set up for people who have been trafficked, so really needs to be a bit more flexible than we tend to be. So these are sometimes individuals who, I will make an appointment with someone on Friday at 2 p.m. and then 2 Mondays at 11 a.m. They show up, and we try to see them, but that's not the case everywhere. And it needs to be flexible in terms of your time, and flexible in terms of the services that you're going to be providing as well. Sometimes there's a language or cultural barrier. We do see that as well. And these are individuals who have often had bad experiences in the past, whether that's with medical care or with mental health or with police or with child protection, and so all of that comes into play when they're trying to decide or thinking about talking about their trafficking experiences, is that they just often don't trust people that are there to help them.
They may also not believe that they can help them, given that their experiences in the past with social services in the various systems, which have led them to essentially where they are today, and haven't been able to sort of intervene in any meaningful way.
So along that sort of line, it's actually pretty rare that we would see an individual come in and say, I'm here because I've been trafficked. Most often we tend to find that adolescents will come in, it's usually for medical care, and it's often because they've been physically assaulted as part of their trafficking experience, or they come in disclosing that they've been sexually assaulted, and when we get more information about sexually transmitted infections, or they're worried that they're pregnant, or they need emergency contraception. We do see adolescents come in where there's some heavy substance use, and also a mental health crisis. So they might be suicidal or self-harming as well. And so it's all about trying to figure out how to ask the right questions, or do an assessment that might get a little bit more information that might lead you to think that this person has been trafficked.
So some of the other indicators that you might pick up on that are maybe a little more subtle when you're seeing kids are kind of outlined in this slide. So and certainly reflected in the case that was presented earlier. The patient is accompanied by a domineering person. Kids are kind of outlined in this slide. So and certainly reflected in the case that was presented earlier. The patient is accompanied by a domineering person. That could be an adult or a peer. In the case of our case, there was both a female peer and then sort of this unknown male lingering about. The patient is accompanied by an unrelated adult patient who, you're seeing maybe over time, and they provide different information regarding demographics, like as far as their address, sometimes like their age changes, different things like that. The patient is a poor historian or disoriented, may seem sleep deprived or the influence of substances. They may have a significantly older boyfriend. I would say the next one is certainly true of the children that are the kids or young adults, the youth that we're seeing, where the ER tends to be their main, or walk-in clinics tend to be their main source of medical treatment. Often kids will have tattoos. Sometimes these are sexually explicit or may have somebody's name or might be gang related.
So in our case, he had offered to give her, to go with her to get a tattoo of a crown because she was a queen. And the idea of the tattoo is also creates a permanent reminder, and it also triggers sometimes for the young adolescents that this could be a long-lasting relationship, that this is something permanent. It's like, I care about you so much, I want you around. This is a permanent way for me to say that you belong to me, and that I care about you so much that I want you to remember me forever, and I'm going to do the same.
Yeah, and I think, just on this note, because it doesn't come up later in the presentation, but some of our colleagues, like in the adult world, I can't say that we've been, so involved or seen this as a major issue with youth, but they try and help facilitate getting tattoos removed as part of like sort of a therapeutic healing kind of support. So often the young women that we see will come in like to the nines, often not looking their age at all. It's there's a real disconnect between what their age is on paper and how they look. Nails, expensive clothes, eyelashes, lots of makeup and things like that. And then certainly we've seen this as well, where every time the kid comes in to see us, they've got a new phone number. So again, some of these, are things that, and as Heather said a little earlier, it, we're kind of struggling with how to identify these kids often. And when you see in the literature that 90% of victims are accessing some kind of health care, and certainly when we've seen testimonials from survivors, they talk about, if somebody had asked, is adolescents who were referred by child protection or police, and there's really good evidence that they've been trafficked, but when we see them, they actually won't say that. So, and we'll talk about our approach a little bit later.
So that really, in terms of, we talked about before, how willing or how open they are to recognizing that that's their reality. And so when, it might have to do with really being able, the shame of being able to identify that this is what you're doing versus using drugs and alcohol and other means to sort of cope with and not feel the feelings related to being trafficked.
So I didn't realize it came up right now, but now we're going to talk a little bit about our approach. And I think this has been iterative as we have tried to be more cognizant and thoughtful about how we see this patient. Always. I mean, we try and do this certainly for adolescents, but we always outline the limits of confidentiality. I think trust, as Dr. Eliav has said, is key with this patient population. We don't want there to be any misconceptions about anything down the line. And probably with this patient population, not a bad idea to repeat the limits of confidentiality at different points. Maybe not every appointment, but to kind of revisit that so that if something does need to be reported to the Children's Aid Society, or there are issues of suicidality, that doesn't become a surprise from them. But I think there's always a way to have that conversation in a positive way, that we're here to make sure that you're safe and want to support you, and that's why some of these things exist. To be aware that taking a history and a physical exam may trigger anxiety or emotional distress for the youth, depending on what their history is. And sometimes I think, I can't say that we do this every time. Maybe Heather, you could chime in, but I sometimes will say to adolescents that, given their history of trauma, sometimes people, to be prepared that having a physical exam can be intrusive, and we always give lots of control over that and say exactly what we're going to be doing as we do it. That for sure we do, but just to prepare them that it might be difficult for them, and that there are different strategies that we can use. Take a history and conduct an examination with the adolescent alone, and this goes for both peers and parents and caregivers. So, I mean, we often get asked the question, how do you sort of propose that to teenagers? And I always set it up right from the beginning that I'm always spend some time alone with teenagers. And depending, we've seen young women who've been trafficked that come in with their parents, a lot who do not, and some of them, even for a physical exam, will want a parent, like a mother, in there. But we want to make sure that we have figured that out, not in the presence of the parent or the peer, and try and take responsibility if there are some boundaries that this youth wants to put in, as far as trying to make sure that we are advocating for them and we're the bad guy, as far as of telling that person that they can't be in the room. We try and take a very realistic, practical approach with this patient population, trauma informed, thinking about harm reduction. As Heather said earlier, these kids are challenging kids in a lot of ways, and a lot of practitioners will not be flexible, but I think this is key. They will not show up for several months, and then show up and expect to be seen right then and there and quickly. So we try as much as we can to be supportive and flexible, and then just to be hyper aware of safety, our own safety as healthcare providers, and the safety of the youth that we're working with. So if they are bringing, if you do understand that the trafficker is safety, our own safety as healthcare providers, and the safety of the youth that we're working with. So if they are bringing, if you do understand that the trafficker is in the building and things like that, there might be certain things that you want to be aware of.
So in our case, that we presented earlier, her boyfriend did come to our program and was sitting in the waiting room for a few of the appointments. She had not identified him as somebody who was trafficking her at the time. So we had our own protocols in terms of, who was in the wait room with him and whether we might need security, which we have in our hospital nearby in case anything were to happen.
She's also did have some sexually transmitted infections and needed some treatment for those. But access to her medication without him knowing. So sometimes it's just, it's being a little bit creative with your treatment, or a little bit creative with how you deliver the medication, can be helpful.
So just some strategies for engaging youth. Really try and develop some rapport, take time with this. I would say, I mean, probably this is with all of our patients, but we really try not to rush. We really try and go at a pace where we can build rapport with them, meet them where they are at. And we don't really mean location wise, although this could be location wise. I know I haven't done this, but Heather for sure has met a patient just to check in, like at a coffee shop or things like that. But you need to be careful about that as well. So build in supports at each level of need. So we talked about Maslow's hierarchy. We dug that out of our brain from school, but they really do. We need to think about the foundation and thinking about how we can support these kids at each of these levels. Treat each session as though it is your last. I think we've learned this over time for sure, that we might not see this youth again. And I think this sort of, because of this is also what our approach really has become, let's at the very least provide a positive healthcare experience. And that's for a few different reasons. One, that we hope that they will come back and they will come and connect here when they need something. And hopefully they then also see healthcare facilities or healthcare providers as somebody who can be supportive. So if they're at a point in their life where they want to disclose the trafficking, that might be somewhere that they turn. Empathy, rapport-based, non-judgmental attitude, validation, and creating a safe space. Consistently follow through on commitments. So do not make promises you can't keep. It's better to say, I'm not sure that we can do that, than to say, we're going to do that and it falls through. I often will say, I can look into that for you. That's probably a go-to phrase of mine. Survivors as experts. So, treat these kids as the experts of their healthcare, the experts of their experience, and give them a sense of control and autonomy.
I think that also feeds in from a psychological perspective. Oftentimes, a lot of us are used to having to get creative in complex trauma therapy and not being able always to stick to our own agendas from a therapeutic standpoint on what we want to tackle in a session. And I think it's very true here. Some weeks you might be in crisis mode, some weeks you may not be. To understand what the needs are of the day and to really take the first 15 minutes to understand those needs will make it a much more efficient and effective session for your client, to know whether it's a session where you're basically just meeting the basic needs, or is it a session where a client may need to spill a little around their experiences of recent and get some support. And the other piece is, when we do build rapport, we try to build rapport so that it's not all connected to the trauma. So we don't want our young adolescents and as opposed to human trafficking. And so, we want to give them the opportunities to have an identity in our healthcare system that's not 100% focused on their identity as being trafficked. So allowing them some space from that to get to know them beyond that, their most recent experiences.
So the next few slides I'm going to go through pretty quickly. I don't think this is rocket science, but we just want to highlight the things from a very medical point of view that we are important to gather and important to look at. So immunizations, medications, allergies, do they have a regular healthcare provider? Is this something that we can connect them with? History of physical injuries and or assault, a sexual health history, mental health history, social history, the HEADS assessment, which I'll go into a bit more, and a trauma symptom screen. So HEADS is a typical assessment framework that we use with adolescents, and depending on how the rapport, I will dive a bit deeper into each one of these things. If I'm just seeing a patient for the first time, I will probably ask a couple of questions in each of these areas, and then over time, hopefully sort of build that out. So home, education, eating, activity, drugs, sex, school, and suicide screen. Some other questions, some people, we've certainly been asked, like, so how do you ask if somebody's been trafficked? What are the words that you use? So here's some examples, but has anyone ever asked you to have sex in exchange for something you wanted or needed, like money, food, shelter, others? So often, so we often think about money, but if somebody doesn't have a place to live, then there are other things that they may be exchanging sex for. And that's what the term survival sex. Has anyone ever asked you to have sex with another person? Has anyone ever taken sexual pictures of you or posted such pictures on the internet? Some other thoughts for screening. So things to maybe ask if, is there previous, when we think about the kind of red flags or what makes people vulnerable, is there previous drug and or alcohol use? Has the youth ever run away from home? Has the youth ever been involved with law enforcement? Have they ever broken a bone, had a traumatic loss of consciousness or some kind of a wound? Has the youth ever had a sexually transmitted infection? And do they have a history of sexual activity with greater than 5 partners? When we assess kids where there are concerns of trafficking, or they have said that they've trafficked, assaulted, and are going to involve the police, then we would offer them a sexual assault evidence kit. We would document any injuries. We would do testing for pregnancy, sexually transmitted infections, and the toxicology screen. We may provide emergency contraception, STI and pregnancy prophylaxis, contraception, sort of more thinking more long term. We would go through the options with them, any immunizations they're missing, especially HPV and hepatitis B, and then think about their overall health, their mental health, and their dental health. And then some of the physical effects that we might see are intentional or accidental burns. I actually saw a kid the other day who had had something on her arm. She didn't really want to tell us, and then she said that she had are intentional or accidental burns. I actually saw a kid the other day who had had something on her arm. She didn't really want to tell us, and then she said that it was her form of self-harm. She had burned herself with a cigarette. branding tattoos, some kind of blunt force trauma. We haven't seen this so much, but firearm and knife wounds are certainly described in the literature. Strangulation injuries, fractures, dental issues from neglect, traumatic brain injuries, neuropathies, and other effects of torture, and scarring. I would say mostly the scarring that we see is from self-harm, cutting kind of behavior.
And some of the time when we talked about being poor historians, some of the time a lot of our patients can't recall exactly how things happened because they may have been intoxicated or alcohol. So you'll get bits and pieces, but when you see the actual physical bruising and impact, they're aware that something happened from those physical pieces, but can't always piece together the whole story.
And then the reproductive health effects, we might see genital trauma, we might see repeated unwanted pregnancies, which certainly was the case with the case that we talked about. You might see abortions or forced abortions, complications from repeated or poorly performed abortions, and then sexually transmitted infections.
So in our case, in the end, she had wanted to have a baby and get pregnant with this particular partner, despite how she soon started to realize that she wasn't again being trafficked. She unfortunately, her baby was apprehended and she was drug and alcohol addicted at the time of the baby's birth. So some of the developmental health effects that we see are delayed physical and cognitive development, and a lot of that can be related to early on trauma, early histories of trauma, as well as drug and alcohol use. We've also seen girls just from a malnutrition point of view, and young adolescents who don't have food to eat come in with implications from that, from vitamin deficiencies and other consequences of chronic undernutrition. And a lot of the time we'll see weight loss from week to week. And so when you really understand the needs, we're able to sometimes support access to food, nutritious food. Impaired social skills, and a lot of that again is related to the early on relational trauma, but also their histories with the various systems involved. And so struggles in terms of who to trust in their worlds around them, and long-term effects of inadequate treatment of common childhood diseases, and that's usually from years of medical or chronic neglect. There's a whole range of mental health impacts that you can see, from panic attacks, sleep disturbances, dissociative disorders, depression, suicidal ideation, substance use. In my experience in working with adolescents who have been trafficked, they often feel like when they present to emerge as and are addicted to either drugs or alcohol, they feel a strong sense of judgment at those times and don't feel like they can access care or taken seriously in terms of their reporting of the issues they're experiencing. But we see a whole range of mental health issues and effects present. When we talk about therapeutic interventions, I just like to remind everybody that the maladaptive coping techniques that a lot of kids have are maladaptive, but we don't want to shift them too quickly and unzip our kids so that they can't function. So they're functioning dysfunctionally with these symptoms. A lot of kids have been in chronic states, and so they may not even recognize the sleep disturbances, the intrusive thoughts as symptoms that they need to reduce. And so some of the time we really have to create, and often young adolescents who are pulled into human trafficking situations, they're surrounded by people who also display the same symptoms, and so that becomes what they perceive as normative. So we want to really first identify what the symptoms are and how they're impacting on their lives, and then work to really reduce the symptoms. The destigmatization, so again, like I said earlier, not making the whole identity of the person about the human trafficking, but being able to show them who they are beyond that and understand and really increasing their self-esteem, and that developing of the self. The prevention of future abuse is really about getting very concrete around risk factors and behaviors, and often it entails going through the grooming process quite slowly and showing examples of it, so that they can start to see and relate their experiences to those, all the while being very mindful of their suicidality and their support systems, before you begin to really provide therapeutic interventions, and building supports and protective factors around the recognized vulnerabilities. We should just be aware that the language we use is important. So first of all, in therapy, you want to use a language that the patient is bringing in with them. So, if they're calling their trafficker my person, or the language that they're actually using, be very specific and clear with each of your patients, their experience. In terms of healthcare providers, we want to maintain professionalism. And so, to use words like sex offender and trafficker as opposed to John or pimp, to look at not, talking about prostitution, but looking at trafficking, exploitation, and victimization. The term child pornography is sort of more publicly now used as child sexual abuse images. And being aware of not only the language you're using amongst professionals, but in your documentation as well. We also provide a lot of advocacy to police, and sort of, I think it's important to recognize that we're working as a whole system together, and we want to really understand that each of us has a role in that system, and be clear with our patients around what each of our roles are, so they understand the role of police, that they understand the role of healthcare providers, and how we all come together. Often kids who are trafficked come from various communities. They may start out being trafficked in one community, they're moved around quite a bit, and there can be lots of systems that are engaged at that time. So how we all work together, and the advocacy amongst all of us is really important.
And I think to add is just that as a healthcare provider and kind of understanding understanding the dynamics of trafficking, you may need to advocate on behalf of these kids. So, whether that be to police who say, oh, she was prostituting, well, that's not quite what's happening here, or to other healthcare providers who, you may refer, our classic examples, we refer kids to our gynecology department for an assertion of an IUD, and then they don't show up, right? And then they get fed up with that. So for kids to our gynecology department for an assertion of an IUD, and then they don't show up, right? And then they get fed up with that. So, those are the kinds of things with some knowledge about the dynamics and the backgrounds of these kids that you might be part of your role.
Okay, I want to leave time for questions, so I'll just go through this very quickly. But we at SCAN at Sick Kids have just started this process, but we have started a project which will be to create and implement and evaluate a community response protocol. So really what we were finding, particularly in the case of youth that are being trafficked or those under the age of 18, is that there were a lot of service providers in the Toronto or the Greater Toronto area, but they weren't really communicating well with each other. There was a lot of duplication of services. Sometimes some of the patients that we would see would be seeing us, and then seeing somebody else in the community, and we wouldn't be talking to each other. So the goal really is to create a protocol so that we can all coordinate with each other, we can communicate with each other, and we can all deliver consistent, survivor-centered, developmentally sensitive, and trauma-informed care, just sort of all across the GTA. These are our partners that we have. So we're in there as well as police, children's aid, so child protection, Boost, a couple of other mental health agencies in the community. We have a breakaway addiction services for some substance use. It's a harm reduction based service in the community. Native Women's Resource Center, and then Women's College Hospital as well actually sees adults. So maybe in the future we might be looking to expand beyond the age of 18. I want to leave time for questions, so I won't go really through this, but basically we are doing a literature review, we're speaking with service providers and experts in the field, we're doing interviews with trafficked youth, with caregivers as well, and we will be doing at some point a focus group for adult survivors and peer support workers. We have developed a community advisory committee that meets once a month. We will be implementing the protocol, and we will be doing a fairly comprehensive and rigorous evaluation. We have actually hired a social worker that has worked with us for a long time, whose entire job will be looking at evaluating our protocol. And the goal, is for, if this is successful, for a blueprint to be created that could be replicated in other communities as well. To just summarize, our take-home messages are that victims often don't self-identify, that they might fall between the cracks because there's this focus on consent, or that they might not identify that the situation that they're in is actually a trafficking situation, that we need to be aware that the exploiter or the trafficker could be present, or that somebody else that's involved in the trafficking, like a peer, could also be present, that youth from all contexts are vulnerable, but that there are risk factors that place some youth at more risk than others. That we found that a trauma-informed and harm reduction and flexible approach has been the most successful for this patient population. And as Karla was saying before, one of our goals is to provide a very positive healthcare experience, and to treat every visit as if it's your last. So to do as much as you possibly can with that youth as they're sitting in front of you. And know your local resources or community resources that you can. I think we have 4 minutes for questions. So the question is, what's the time frame for the development of your protocol? And it's 5 years, actually, so it's a long time. We've given ourselves plenty of time. I think that I don't know how long the actual protocol development will take, because that includes the evaluation of it as well. But I think it'll probably be a process that we, develop the protocol, evaluate, and then, make some changes to it, and it'll be a bit fluid.
So in this scenario you presented, was the friend who was with the youth victim associated with the trafficker, or could you determine that? Sometimes those who are trafficked are forced to recruit, control others. So it was our strong suspicion that the friend was connected with the trafficker, and the trafficker being downstairs. I think that the point that we were trying to illustrate there is that it was a female friend, and that sometimes that may allow us to feel more safe and provide information that's confidential amongst that person. I thought it was really interesting that she came in as the person who held all of her history, her social, emotional, medical history, which gave the friend quite a bit of control. I didn't want to take the friend out of the room right off the bat, or I thought we wouldn't be able to build trust and rapport. But in the second session, I was able to negotiate the friend leaving the room. But that did change my approach in that first session. And we'll send the video to Pearl. You can email Pearl. Pearl will send it out to everybody. And we just like to mention that we contacted the young woman who did the video, and it was with her consent that we will provide this information.
Yeah, and I would say it's definitely worth a look at this video. Jade is the young woman in the video. She's doing a lot of work in trafficking and prevention and support of victims, but she does a really nice job, and she was very supportive of us using the video and teaching.
Thank you very much, everybody, for this opportunity. And if you have any questions, you can reach out to any of us after this. Thanks.
Thank you.